Good evening. Welcome to Let's Talk About Health. We are live on Facebook and YouTube. I am your host, I'm Mrs. Winnie Ohine-Kisi, and the show is Let's Talk About Health. Before we get today's proceedings going, let's take an advert. We'll be right back.
He's meticulous, very detail-minded. He likes to think outside the box. You leave a work to Christ and you are sure you'll come back to meet your best. And we were working together nicely before he had this intention of starting his own business. He discussed it with me and I endorsed it and I let him go. And ever since I've been working with him, I disposed a couple of properties. I did it through him, and that was done in a record time. And I will always recommend Christ for anyone who wants to deal with properties, to deal with Christ and have the peace of mind and also have assurance that he will have the best deal.
Christian is
At World Remit, we understand what the journey is about. How it can sometimes take a little distance to bring us a little closer together. With ways to save more when you send more, World Remit is here for you, so you can be there for them.
Welcome back, everyone. If you haven't joined us, we are live on Facebook and YouTube. Tonight's show is on diabetes and eye health. And in the studio to do this with me, I have a fine young man. But before we do, let me take this opportunity to say a big thank you to Nana Adwa Asante. She gave an incredible account on her struggle with sepsis. And Nana Adwa, I know you are watching me, you are tuned in because you always do. What an awesome account you gave to us. I hope you'll be back to do the part 2, like we said. So we will get the ball rolling because I think we are behind time now. I'll let my guest introduce himself and then just tell us what you've been doing.
Sure. Thank you, Winnie. My name is Adam Mapani. I'm a consultant nurse at Moorfields Eye Hospital. I'm also a clinical teaching fellow at UCL, and I'm involved with quite a number of things. I've been working in the medical retina service for 18 good years, and also I've been involved with clinical care, innovation, education and training of allied healthcare professionals and nurses.
Wow. So all this tells me you are an extremely busy nurse. And we should just give a shout out to all the nurses out there because it's been a week this week, isn't
Absolutely.
it? And it was International Nurses Day yesterday. So congratulations to all the nurses for all the good work you are doing out there. Adam, I know you are so busy. And if there is any topic that I would be interested in, it will be diabetes and eye care. Why is diabetes such a problem with the Black community, and why should we be particularly concerned about this topic?
Sure. So that's an important subject area because diabetes is a pandemic on top of another pandemic. So COVID-19 before and after, we're seeing huge challenges with the diabetes mellitus as a disease. We know that in the UK, from statistics, there's about 4.7 million people living with diagnosed diabetes. Yes. And what's worrying that there is approximately 1 million people with undiagnosed diabetes. So the undiagnosed diabetes cases, they are people who then end up showing either in an eye clinic or eye casualty department with some form of severe complications which are preventable. And that's quite worrying. And I think what we also have to realize that diabetes mellitus is a disorder. There's variation in terms of populations such as Black minority ethnic groups, men at risk of times fourfold of developing type 2 diabetes. And we know that from statistics. So it's very important to take it very seriously and also to look at opportunities such as lifestyle modifications to prevent it from developing complications.
Right. So should I assume that anyone who will be having a diabetic eye problem would be essentially diabetic before.
So
is that how it works?
So the way how it works, we need to take a step back. So there is what we call the National Service Framework, developed by diabetes, by the National Service Framework that was developed by the Department of Health at the time in 2003. So for people living with diabetes or those diagnosed with diabetes, it is recommended that they attend retinal screening once a year. So from a journey of being diagnosed with diabetes, high blood sugars, you go through variation process, fasting, blood tests done by your gatekeepers who are the GPs, and on diagnosis of diabetes, you enter into a diabetic register, and automatically your GP will refer you for retinal screening, which is a community-based social model of care done locally close to where you live.
Yeah, right. So, you know, recently we've heard a lot about ethnic minorities and blacks, Asians, and all that. Is there something we are not doing right, or why are we so predisposed to diabetes?
Yes, so there's something about genetics. So there's the genetic factor, which there's very little you can do about it. So there's that genetic risk factor. So we know that from a black community, someone of a black population background, they're at risk of developing diabetes. So is the Asian community as well. Right. So there's that genetic component. And then there's also some other component factors that we see which can be modified in terms of modifiable risk factors, things like body mass index, and in some population group you would have to measure what we call waist-hip ratio. And there's also something about blood pressure. So for those with the history of blood pressure, hypertension, they're at significant risk of developing type 2 diabetes. And then we also look at the other factors such as cholesterol, that puts again at risk. So, and then age factor as well. Yeah. So those there are opportunities to modify and reduce the risk through lifestyle modifications.
Right. Yeah. I mean, for those of us who are watching for the first time, we have had a session on diabetes with a general practitioner, so they can actually go back and then have a view of that episode, and they will have more detail on diabetes as a whole. But tonight, I think our focus will be on eye health in relation to diabetes, isn't it? So how do we detect that one has eye disease because they are diabetic?
Oh, right. So that's a good question again. So the way how we would understand it, so we look at it from a retina point of view. So the retina is the thin lining behind the back of the eye. So interestingly, it detects the light and send the signals to the brain, when then the brain denotes for vision, so that you can see this colorful, wonderful world. And the retina has got blood vessels, and those tissues, if they are damaged because of high blood sugar, hypoglycemia, it can cause the central part of the retina, in this case the macula, which is responsible for fine driving vision, and it can cause swelling of the retina. When there's swelling of the macula, it becomes oedematous, and that can cause visual impact on the central vision or driving vision. And then the same disease again can affect the peripheral side of the retina. It can cause blood vessels to close. And then when there's closure of blood vessels, there is formation of abnormal blood vessels, because somehow oxygen is compromised, supply of oxygen and blood. And when there's that compromise, there's formation of abnormal blood vessels. And then because these abnormal blood vessels, they're fragile, they can break easily, cause hemorrhaging of the back of the eye. So that's that part we call proliferative diabetic retinopathy, which is associated with visual blindness.
And will the ordinary person be able to tell? How does it manifest?
So going back to that question again, so in the UK, we've got something phenomenal that has already been reported in literature to reduce the risk of blindness. Okay. So this is what we call diabetic retinopathy screening service, which has been since long established from 2003. It's a fantastic model because it's able to identify sight-threatening disease early. So the way it works, if for those people living with diabetes in the community, they go for screening. So it's important that they attend annual screening. So when you go for screening, it's a smooth process. You'll be seen by a group of very well-trained staff who are called retinal screeners. They're able to check your vision. They're able to take history, put some drops so that we can take the pictures of the back of the eye, which is the retina. And on average, it's a process that takes 10, 15 minutes. When we take those pictures, they get stored, saved, and with some form of very digitalized software, they are forwarded to those who are able to interpret those images. And those images will help us to detect any sight-threatening diabetic eye lesions. So when we see the pictures, we are able to identify whether someone is at high risk and or someone is probably low risk, well controlled. So on that, according to the National Screening Committee guidelines, so for those who present in screening with sight-threatening conditions such as bleeding of the back of the eye or some form of abnormal blood vessels behind the back of the eye, the retina, they automatically get referred to an eye clinic department within 2 weeks to see an eye doctor and to initiate a robust clinical management, which will come into it when we discuss about treatment options. And then for patients or people living with diabetes who present with something like the swelling of the back of the eye in the macula, it's slightly different, it's low risk. They get referred to the same eye clinic to see an eye specialist, to see someone within 12 weeks. And it works really well because of digital transformation in the NHS. We talk of e-referral. We talk of efficient because of digitalization equipment, and they get seen very efficiently in the digital pathway until they see someone on face-to-face.
Oh, that seems like a whole lot, isn't it?
Yeah.
I mean, for a lot of us who are watching, we would think that we should be only worried if we are diabetics. Should this regular screening or yearly screening, should it be a concern for those who don't even have diabetes?
Yes, so I think let's focus for those who have got a diagnosis of diabetes.
Right.
So for those who have got a diagnosis of diabetes, they should be attending retinal screening,
right,
which is offered to them automatically by their GP.
Okay.
So from my experience of having worked in retinal screening with colleagues, it works really well because those appointments, they are managed robustically so well. And it's an annual screening. And if there's any problem, there's some form of recall. If there's any changes at the back of the eye, they get referred to an eye clinic department.
Wow. It seems
and then
like
for those without a diagnosis of diabetes, this is where they need to see primary care providers such as their local opticians.
Just their usual...
just for a routine eye check.
Oh, okay.
Yeah.
So that is quite clear.
That's quite clear.
So, it is not just because you are, say, black or ethnic minority to be concerned, but it's something that the whole population, because obviously
Absolutely.
the numbers in terms of statistics is quite staggering, isn't it?
Yes,
and that's
yes.
across the general population.
Absolutely.
Not just to do with... blacks and Asians.
Yeah.
So I have been seen by a doctor because I have diabetes, and then I have been referred. What should I expect when I come to a clinic?
Lovely. So when you come to a clinic, so we are now talking in COVID, and the pathways have changed slightly different, so that we can account for everybody.
I can
so
imagine.
The impact of COVID-19, we have lost so much time, and kind of like 6 months of work that is waiting to be executed.
Wow.
And for your own information, ophthalmology, it has got the second highest of outpatient activities after orthopedic subspecialty. So it's important now to think about the digital transformation and how they've changed pathways for people living with diabetes. So once you have been identified that you need to see someone in the eye clinic, when you get referred, you either go through what we call digital hubs, which is something that is now kind of like well established nationwide in most ophthalmic services. In those digital hubs, there is no physician contact, to make it very clear, but there's a group of very well trained staff called ophthalmic technicians whose main role is to get the history, diagnostic base tests, as in visual acuity. They take pictures of the back of the eye, the central part of the eye, and the peripheral side of the retina. And they check pressure inside the eye, and then the patient is told to go home. The nicest thing about this pathway, it's quicker,
Okay.
it's smooth, and I know for people living with diabetes, it's a multi-system disease. So they might have another appointment in the day, or they want to go back to work, maybe they fall within the working age group. So there's a very much swift process. And in those digital hubs, we have got robust systems that images can be reviewed in real time by qualified personnel such as physicians, optometrists, nurse consultants, and so forth. And then if there's a problem, as in those with severe diabetic eye disease or some changes that require treatment, they get referred to see an eye specialist on a face-to-face. So if there's any form of vitreous bleeding or there's any form of hemorrhaging behind the back of the eye, they get referred within a week to see an ophthalmologist for treatment. And then if there's any form of leakage or swelling of the back of the eye, they get an onward appointment heading to the injection pathway for treatment. And then for those who are kind of like borderline, who don't necessarily need immediate treatment, we continue to monitor them in those pathways. And then those who are sort of false positive, in the absence of nothing at all, we say goodbye and we refer them back to the screening services.
Yeah, I think all this will make a lot of sense if we have some images, isn't it, to support
Absolutely.
this.
Absolutely.
Because even for somebody in health,
Yes.
it's a bit like, it's very graphic, and you'll be imagining things like, what are they talking about?
Absolutely.
So let's start with this particular diagram here.
Yes, so we can start with this particular diagram, although we should have brought it in earlier. So this diagram just show the back of the eye. So we talked about the macula being a thin lining behind the back of the eye, and we also talked about the macula. As you can see on the macula now, that's responsible for the quality, the fine vision, and any complication that you tend to have because of diabetes is either the bleeding, which is a vitreous hemorrhage, or you can also have the swelling of the back of the eye. Now, you can also have something that can manifest on the optic nerve as some form of abnormal blood vessels. Now, if we go to the next image,
Okay. Yeah.
please.
So this very image is not a diseased eye, or it is a diseased
So that's
eye.
kind of like a presentation, but now this is a diseased eye.
Right.
So the images here, I've sort of put them in form of a traffic light system.
Okay.
Right.
Yeah.
So the concept of traffic light system is widely used
Yeah.
in healthcare. It's also widely used in public health. So if you go to Sainsbury's, you go to Tesco's, foods are categorized in terms of content, yellow, green, and red in terms of salt and other things. Now, the first image, which is background diabetic retinopathy. So this is kind of like on a traffic light system. This will be like green,
Okay.
right? So at the green stage, it's okay.
It's okay.
There isn't anything to worry about. So you see that in that eye, there's some very subtle changes behind the
So
back
this
of the
is
eye.
at the back of the eye.
Yeah, so this is now the back of the eye, what we are looking at. And you see that there's the optic nerve that looks yellowish, and then you've got the macula, which is responsible for your central vision. And then there's some fat deposits coming out within the central part of the retina. Again, there's nothing to worry about because it's far away from the fovea. And then in the peripheral side of the retina as well, there's some very subtle changes. So at this stage, in screening, these are patients that are monitored at screening level in the community. They don't
Okay.
have to come to the eye clinic department.
All right.
And the nicest thing is you are within the comfort of your home. You go to screening, get your eyes checked, and continue every year. And then when it gets to this stage, if it's in screening, right, so that becomes quite agent. So we would put this as AMPA, which means there's a need to see someone.
Okay.
Yeah, so this is an automatic referral to an eye clinic department. Why is it a referral? As you can see, there is some blood, there's some fat deposits in the retina, and then in the peripheral side of the retina, there's some X-ray, there's some microaneurysms. Anything that is there is related to diabetes eye changes. And this case would automatically meet the criteria for referral to the eye clinic department.
Okay.
And then at the red sort of stage with that case, which is the proliferative diabetic retinopathy, it's not good news because there's formation of abnormal blood vessels. So going back again to what we said, that if there is lack of control of diabetes, there will be formation of abnormal blood vessels because of the lack of oxygen supply, deprived areas because there's no continuity in terms of supply of oxygen and blood. And then there's formation of abnormal blood vessels, which are so fragile. And these cases, they need to be seen in the clinic to initiate treatment, such as laser treatment.
For a lot of us, it looks like if we cannot physically see anything happening, like at the front of the eye,
Yes.
then we assume that we are fine. And these images are coming from the back of the
Yes,
eye,
yes.
isn't it? Is there anything like at the front of the eye that would be suggestive?
So you will not necessarily. There are. I mean, if we go to the next stage, please. The
Okay,
next
the
diagram.
next.
Yeah. So you would not see sort of things that manifest, but there is something around proliferative diabetic retinopathy, which is a severe complication. And there might be, on the clinical examination, some vessels in the iris or something that might be an indication, but you won't see it yourself. The symptoms that you tend to see either could be blurred vision because of the oedematous in the central part of the vision.
Right.
And in some cases, they might see floaters, right? And some people might report floaters, and which might be associated again with proliferative diabetic eye disease.
Floaters. What are
So,
floaters?
so behind the back of the eye, you have got a jelly-like substance called aqueous humor. And as we grow old, in some people without the history of diabetes, it can sort of melt down like jelly. And for some people with diabetes, I'm not saying that can happen to everyone, but it can cause some floaters. And that would be a concern because you would need to see someone urgently.
You need to see.
Now,
right.
so the whole thing around screening is to detect and see, because in majority of cases, some people might have retinopathy or might have diabetic eye disease, but without knowing, and because the symptoms tend to vary a lot compared to other conditions that we deal with.
Right, that physically manifests.
Yes.
Right. So on this particular diagram, can you talk us through? So
this is the progression of diabetic retinopathy, and what you tend to see again for people living with diabetes is to just sort of imagine again when there's been a history of hyperglycemia, oxidative stress, or inflammation, or someone who could not control to achieve good blood pressure and diabetes management. So in this diagram here, where it starts with some very mild subtle changes at the back of the eye, and we then see some signs of swelling at the back of the eye, and swelling at the back of the eye is the biggest cause of blindness, because that's what you use for your central vision. And then when there's complications of proliferative retinopathy, this is now the formation of abnormal blood vessels, which are quite fragile, and they can sort of bleed easily. And what we also see is the role of blood pressure in some people with a history of hypertension. So with hypertension, again, it can cause certain clinical features such as cotton wool spots and these things, again, as they manifest as we progress, they have an impact on the presentation of the retinopathy.
Wow. I mean, this is really like full-on stuff and will be scary to a lot of us even watching. But the most important thing is to seek treatment promptly, isn't it? Viewers, if you are watching us, we are live on Facebook and on YouTube through Omega Live Studios. And this is coming your way by proud sponsorship of World Remit, the safest way to send money to your friends and family back home. I've got Mr. Adam Mapani with me tonight, who works in a very reputable hospital here in London. It's an eye hospital, isn't it? Yeah. And he is taking us through all we need to know when you have diabetes, and then the possibility of getting eye problems as a result of just having diabetes. So Adam, I'm thoroughly enjoying the session so much, because as you know, this is way out of my scope. So it is very, very interesting. So thanks so much for taking the time to come and show us all this. I mean, for anyone listening, their worry will be, if I should be diagnosed with this and get to this stage, what should I expect, or is there any treatment that will be available to me? But before we go into treatment, is there anything, because I think the best thing is to prevent it, isn't it? So we don't even get to the stage. So shall we look at any ways that we can prevent this from even happening?
Absolutely. So prevention is always a preferable route than treatment. And what we see, again, with opportunity to adjust in terms of lifestyle modifications, it brings significant benefits in the sense that this is something that is long-term. It's a chronic disease. So the areas that we can discuss about is backed by evidence. So there's a big study that was done many years ago in the UK, known as the United Kingdom Perspective Diabetes Study Group, UKPDS. So UKPDS demonstrate in terms of evidence show that good glycemic control and good blood pressure control, in no doubt, will significantly lower the risk of disease progression. So intensive blood pressure management would show a 37% decrease in microvascular endpoint. So by just making sure that you have a very good, well-controlled blood pressure. And then for hemoglobin, HbA1c, achieving a 1% reduction in HbA1c, again shows 37% decrease in microvascular endpoint. So in other words, there's significant amount of benefits in lowering HbA1c, lowering blood pressure. By doing, how do you achieve that? So this is where lifestyle comes in. Have a dialogue with your GP, your local diabetes specialist nurse, and things like physical activity, things like running, jogging, things like eating healthily, beetroots, things that can lower blood pressure. We also see significant benefits on kind of like trying to minimize stress, which can also have an impact on the body. So those are key important areas that people, especially from our community, again, looking at the disproportionate impact of diabetes on the Black minority ethnic groups. So it's very important, again, to try to exercise a better lifestyle.
A better lifestyle. I mean, that brings to mind, think glucose, isn't it?
Yes.
Are you controlling it well? And it will be the first step in...
Absolutely. Achieving good control. Another opportunity, again, even for those living without diabetes, is to know your numbers, right? So knowing your blood pressure, knowing your cholesterol, knowing your HbA1c, knowing even your waist, trying to go for body mass index. So Diabetes UK, which is an umbrella, which is a patient society body in the UK, they've come up with something very interesting, which is very useful, a practical tool to try to measure the risk.
The risk factors,
the risk of developing diabetes. But also some areas where someone can also exercise a good lifestyle. So very important, again, to try to look out for those information, educational resources, so that it can help yourself in preventing some of the things that we've discussed.
Right. So I think that will go a long way so we don't even get to the stage. So
Yes.
we've got this next slide which says advanced diabetic eye disease.
So unfortunately, this is now something that, you know, if diabetes is not well controlled and things have not been working, blood pressure, glucose, it gets to end stage diabetes, which will damage the back of the eye. And according to clinical evidence, it is the cause of permanent visual loss and blindness among patients with diabetes. But here's the caveat: screening. It shouldn't get to this, right? So there's a routine screening, which according to evidence literature is reduced cases like this.
Okay.
So before it gets to that, there is an opportunity to go and get your eyes screened. There's an opportunity to speak to your gatekeepers, your GP, diabetes physician, dietologist, diabetes specialist nurses. The community is well supported. The government is spending so much money to try to fight and support people living with diabetes. Yeah, so this is a true manifestation of advanced diabetes. This is bleeding. And when it gets to bleeding, vitreous hemorrhage, this is quite worrying because blindness, vitreous hemorrhage or bleeding is associated with blindness.
Right.
So that becomes quite worrying. And we also see certain things at the front part of the eye for people who have got severe diabetes, which can cause another complication known as glaucoma. And then at the very end stage now, when things have failed, there might be then now the very late stage diabetic eye disease with fibrosis and the retina pulling, traction. And on that diagram there, this is where now it goes beyond what was managed in the medical side of the retina. You would need a surgical clinical management, which might involve a surgical sort of a clinical management, seeing a vitreoretina specialist to discuss surgery, to discuss vitrectomy, some form of interventions in order to address the situation.
Right. So that brings us to treatment.
Yes.
I mean, all this sounds very scary, especially when you have the diagnosis of diabetes.
Sure.
Will every diabetic get to this stage?
Good question. From what we know, there is duration. There's the risk of duration and duration of diabetes. So type 2, type 1, type 2, after 2 decades, there's slowly some changes at the back of the eye.
Yeah.
And for similarly to type 1, so the longer you've got diabetes, the more likely to develop diabetic eye disease. That's what we know from from evidence literature. Whether it gets to this stage for everybody, not for everyone. So there is control opportunity in terms of how people manage their own diabetes, as in lifestyle. So very, very important to exercise good control. So for some people, they go for 30 years with very subtle minimum changes behind the back of the eye. And for some people, unfortunately, they develop complications.
Yeah.
Yes.
I mean, at the end of the day, you want to know that there's some kind of hope and this can be resolved or treated, or,
Yes.
what are the treatment options?
So the treatment options are pretty much effective. So when everything else, lifestyle has not been, has failed and people develop complications, the diabetic macular edema, which is the swelling of the back of the eye, is treated with intravitreal injections into the eye.
Okay.
That might sound again scary,
Yeah.
but this is now like a gold standard in the management of diabetic macular edema.
All right.
So injections through clinical research in the last decade, it has redefined the retinal landscape in terms of effective treatment. So clinical outcomes is absolutely amazing, and visual visual restoration or stability with injections into the eye, again, significant amount of evidence.
Yeah.
Now, there is also laser treatment right? Laser is a therapeutic for the peripheral, for the diabetic retinopathy, which could be vitreous hemorrhage, the bleeding, or the formation of abnormal blood vessels. So that is treated with what we call pan-retinal photocoagulation laser treatment. So the use of light energy to destroy those abnormal blood vessels.
I mean, all these are very technical stuff and need proper, professional people.
Yes. So for injections, they are done in clean rooms. So for a pathway-wise, so if someone is diagnosed or someone is said to have diabetic macular edema or leakage behind the back of the eye or swelling, they get referred to see a specialist. On arrival into the eye clinic, you get scans done of the back of the eye to detect fluid, and in some cases we also do a retinal angiogram, fundus fluorescein angiogram. And the purpose of this is to understand the circulating process, or to understand what really is the extent of the damage. So it's an invasive procedure, put a cannula into the vein of the arm of the hand, and then we push it, give it the first bolus, and there is photographic surveillance, lots of pictures of the back of the eye. So it's a yellow dye test, which is effective to diagnose whether there's also ischemia or any changes with oxygen supply. And that's kind of like the gold standard. But we also, technology has revolutionized the way we understand the disease. So some of the stuff is non-invasive. And after those investigations, you sit down with a practitioner, with a clinician or an ophthalmologist. It's a partnership, it's a dialogue. We present the findings, we present the extent of the damage. Now, if it's swelling of the back of the eye, and we can make a decision actually to say that there is an opportunity to reduce, there's an opportunity to exercise good control, there's an opportunity to make some lifestyle modification.
Right.
So it's not always a case whereby you quickly jump on it. But even at that stage, we do introduce the subject of public health. We do introduce diabetic education. Now, at Moorfields, we are quite lucky enough that we've got a dedicated diabetes specialist nurse. So once we identify someone who has got some complications, they get support from a diabetes specialist nurse. We can provide disease counseling, a conversation around treatment, a conversation around how they manage lifestyle and so forth. And this colleague of mine is very good, and she has demonstrated again and again a good work in providing disease counseling either over the phone or on face-to-face. So this is diabetic macular edema. And if we identify that that is the option, we delay treatment and bring someone back in 3 months. Right. And that way we give them the opportunity to exercise good control.
Yeah, it's
but
safe.
Then,
finish
the other
that
side of it is the proliferative, which is the sort of the advanced diabetic eye disease. I think at that stage we tend to quickly jump on it to apply laser treatment.
So it's safe to say that it is not going to be a one-off visit to the clinic.
No. So if it's a clinical management, for example, with injections, it's a course of 5 injections over a period of 5 to 6 months. And then you get reviewed by the consultant whether you need top-up injections. Yeah, for laser treatment, it's sort of a bit of time coming in for laser. It could be every 2 weeks or it could be every week until we feel that things have improved.
I always gather from having these sessions that especially to do with our community, Black and Asian communities, that our compliance to treatment is always poor. Is that the case, do you think?
Yes, that's a very interesting subject. I think there's something about variation in attending the eye clinics themselves. So when it comes to variation, clearly, no doubt, evidence has shown that there's variation in attending eye clinics from our community.
Yeah.
So there's something about missing scheduled appointments. And then there's also something about, when that appointment is missed, especially on a overwhelmed NHS like now, you might be lost in the system.
Yeah.
Yeah, so that's quite worrying. So I would say very important that if you've got a scheduled plan for management of your eyes, please make sure that you attend those appointments. Literature has also shown that there's very good reasons why people would miss appointment. In some cases, like within our community, maybe when it's winter, maybe we go somewhere nice into the tropics, enjoy some sunshine, and then come back to the UK when it's summertime, and especially before COVID. And we've also seen that from kind of like our community again, especially among men, who are less likely to see their GP,
Right.
and possibly some other suggestion according to literature is that they work long hours and thereby end up neglecting their own health. So it's important again that you know that if you've got a scheduled appointment, you attend. The nicest thing about diabetes now is that there's all these regulations, like for example, diabetes and appointment and employment, which protect the individual.
Right.
So when you declare to the employer will support you, will give you the opportunity to attend those scheduled appointments. So important again to sort of look at it from that practical point of view, employment and diabetes. Then there's also diabetes and driving. So if you're a bus driver and you're living with diabetes, you miss scheduled appointments. Not only that, you're putting yourself at significant risk of visual loss, but your family as well, because there might be loss of income.
Yeah.
Because DVLA is very clear as to qualify for driving. So again, it's all those factors again that needs to be considered.
Yeah, I think that's one thing that will be of interest to a lot of people, because I do know that, especially in London, there are a lot of drivers who are in our kind of communities,
Absolutely.
isn't it?
Yes.
Yeah.
Yes. Yes.
But there's always help for
Yes.
these people, and
Yes.
they shouldn't be sort of penalized or for having to go for all these treatments and all that.
Absolutely. So, and another thing is to have an open dialogue with your physician. So, as I said at the beginning, you prepare to go for an appointment. Get your medication history, get important information, jot it down. If you are using a smartphone, enter it somewhere. And then when you get there, talk about the practicalities of social life. You can even mention that this is how busy you are. There is a chance that you might sneak out into somewhere into the Caribbean, or you might go to Ghana. Have that open dialogue. Why I say so, there may be some treatment options which might meet your individual needs. So it's important that you help the physician to help you.
To help the physician, absolutely. Yes. And there's no way you can make progress if you don't go along those lines, isn't it?
Yes.
The interesting thing I find is the depth of knowledge of all these nurses who come, on the show. And listening to you, I know you must have done so much to get to this stage. Can you tell me a bit about your own career pathway?
Oh, interesting. So I was quite lucky enough that I joined Moorfields Medical Retina Service in 2003. Okay. So I've been at Moorfields for 18 good years. And in that career pathway, I'm so grateful to the great mentors, finest leaders, innovators, and my colleagues in management, colleagues in nursing, medical, and the whole consultant body, medical retina, who have supported me in my own progress. So over the years, in the last sort of 15, 16 years, I've been involved with advanced practice, diabetes, which we are talking about. I started as a retinal screener in Myland, Tower Hamlets, which is quite like a rich sort of borough in London with diversity in population. And then from Tower Hamlets, I then I stayed there running retinal screening on an honorary basis. And then I was also involved with advanced practice at Moorfields, seeing patients, and also being able to make clinical diagnosis, being able to read OCT. So again, through the guidance, mentorship and coaching of my colleagues, the trust from my managers, from my leaders, I was also put on a career pathway to take more and more extended roles in terms of clinical practice. And I then found myself leading on those various areas. But the kind of like the sort of milestone of my career is when there was the discovery of the injections through research in 2008 through some clinical trials. And at the time, there were less number of doctors to administer those injections. And I was quite lucky enough again to identify an opportunity, get supported, and look for options for nurses as the role model in administering injections and lead on it. And that was again another opportunity that came my way with the support of my colleagues, my team that I work with.
Yeah, so is that what you do on a daily basis? Is that the injection side?
So on a daily basis, so this is kind of like a variation. So there's the injection side, and then there's the education and training side. So for example, with the injection model, after having gone through training, I've trained others.
Okay.
And by others, trained more than 1,200 people in the UK and around the world, as far as Australia, Singapore, South Africa, and Hong Kong, in Europe. So I've been leading on training, and also innovation-wise, not just injections, but also being able to make robust diagnosis, digital innovation, and also as an honorary clinical fellow, I was also able to have an opportunity to teach and train others with an academic institute.
Right, so I can safely say that for people like you, these kind of specialized services should not only be in London. It should be within reach throughout the country. Is that what it means?
So there is eye clinic departments everywhere in the UK. Moorfields, they've got several eye departments. They've got several satellite clinics across around the M25. So in the east side of the town, not far from here, there's Moorfields in Stratford.
Yeah. Talking to you prior to the show, obviously I gathered a whole lot of things, and I know you've had you've been awarded doing certain activities. Tell me about that as well.
Sure. So again, leadership being about people, and also being about, not followers, but how many people you've supported, something that I'm passionate about. I think I was quite lucky again to have the trust of my colleagues, and also my friends, the community around me, to have won quite a number of awards in my career journey, more than 10 awards. So I think there's kind of like the most significant one include the being identified or winning a hotspot in the ophthalmology power list. So I featured on the ophthalmology power list in 2019.
Wonderful.
And also I received a gold award from Ruth May, Chief Nursing Officer for England, in 2019. And also I been nominated for a global award called through the Tolbeck Foundation. And most recently, last year, I had received a recognition from Prime Minister Johnson, and I was invited to number 10.
That's very impressive.
Contribution.
Yeah, well done. I mean, I'm not surprised you are piling on all these accolades, because I was introduced to you by a friend.
Oh, right.
And you were just so keen to want to come on to educate people, isn't it? So I'm sure you are very well deserving of everything that you have achieved so far. But you do other things as well, isn't it, for the community? Tell me about your community projects as well. Sure.
So I think it's also being about responsive. And I also thought about my career, the opportunity that I've had, and the support that I've had at Moorfields, my family and friends. I looked at, serving the underserved. So the number of things that I'm involved with, I'm also involved with charitable work. With my colleague, we co-founded a trust called Abalone Trust.
Abalone Trust,
yes.
Okay.
Which is an international eye health charity to support eye care in the developing world. And we've done some work in Zimbabwe, we've done some work in Kenya.
Are you originally from Zimbabwe?
Yeah, I'm originally from Zimbabwe. Yeah.
Okay.
Yes.
Yeah.
And most recently, in the past year, unfortunately because of the pandemic, we also saw an opportunity to make a difference.
Right.
Charity begins from home, so here in the UK. So last year I was quite lucky enough to have been identified or invited by NHS England to drive a campaign on diabetes prevention and awareness in Black minority ethnic group. And it worked so well because I was quite active with my colleagues from the Avalon Trust and also my wider colleagues in the NHS, running webinar sessions in the evenings to empower people with information on lifestyle, education. And we did that so well. And we were working with barbers, we've worked with community leaders, faith groups, and we've also worked with other fellow like-minded ones, organizations.
And what exactly do you do with these groups?
So it's mainly about educating.
Educating people.
Educating the people.
Yeah.
So education is power, information is power, because we see the role of missing information. And if diabetes and blood pressure showed disproportionate impact in terms of COVID and the Black minority ethnic group, so it's also very important that we get the message across to the people. And this is where I just sort of identified as an opportunity to make a difference.
Yeah, and I love that because I
Sure.
think we are on the same page when it comes to wanting to share the knowledge that we have acquired and
Yes.
getting all our friends and family involved in it as well.
Yeah.
So we are nearly an hour now.
lovely.
Yeah, pretty much. But I am quite interested in your work back in Zimbabwe with this trust, your foundation. Can you tell us exactly what you do? Because obviously, like all these pathways we are talking about and all that,
Sure.
it is a totally different story when you get
Sure.
back home. And that's
Sure.
where the problem is, isn't it?
Absolutely. So I think it's worthwhile to mention that as part of giving back to the community,
Definitely.
sharing the knowledge, so it comes from that pure heart in terms of paying back to the community.
Yeah.
So having said that, came up with a group of friends who share the vision, the passion about improving eye health in underserved communities. So what we've done in Zimbabwe through the support of my colleagues, we've been to Zimbabwe doing some eyes camps, supporting eye care, eye screening in Masvingo. We have also done some work in Buhera. We've also done some work in an area called Mutasa in eastern Zimbabwe. And we've done also some form of education and training. So we've identified 3 senior nurses that we have been coaching and training online, virtually, but also looking at supporting them with some resources.
Right.
So I'm pleased to say that two of the senior nurse practitioners we have identified, one from the Matabeleland side, one from Mashonaland side, are already working towards a retinal screening course so that they'll be able to, similarly to what we're saying here, to educate and look after patients with diabetes. So they're doing some courses with a higher national diploma with the University of Gloucestershire, and we have supported them again through educational initiatives. We've also done some form of coaching and mentoring, especially for those kind of like young, looking into a career pathway in eye care. So that's something again that we take pride in, mentorship and coaching, and so those are the areas.
And how do we fund all this?
So
How are you
go
able
to our
to-
website, www.abalontrust.org.
Yeah. Okay, and then they can sort of follow.
Yes.
Yeah, and
Yeah.
can they contribute towards your
Yeah,
activities?
I think in this modern world of digital innovation, people can either sort of shout the message in support, solidarity, or they could also give us a shout if they are happy with our work. And for those who are generous enough, there is opportunity to donate, either in kindness or their own time to commit to it.
Yeah.
Yeah.
Obviously, we have people who have joined us from all over and watching us live. So some of them you may well know. So let's see, because I tend to go through that and see if you have any of your colleagues supporting you.
Sure.
Let's see. I've got Ree Mapani, that may be your family member, has joined in and watching. And we have, is it Maimi Kwenda? Not sure. Yeah, you do know them, yeah? And our own Queen Harriet of Omega TV saying great show. And I'm looking gorgeous. Thank you, Queen. Yeah, but there is Annetta, I don't know whether it's one of your colleagues, says early diagnosis, early prevention, early treatment, save people's sight.
Yes.
Yeah, is it one of your colleagues?
Yes.
And then obviously Doris, who introduced us, is watching. June Reed is watching. Everyone is saying it's a very educative program, and I have my guest for the previous show who gave an account on sepsis, Nanajwa. I'm saying it's very educative. Guys, keep sharing so we can get this message far. That is the whole point of doing this. A lot of the people probably are just your colleagues, and they are saying Helen Carpenter, great health promotion. Adam, yeah. So do you know Helen Carpenter?
Yes,
probably one of your colleagues. Yeah. And most of them will also be my friends. My husband is also watching. We have a number of pharmacists, and Duchimesi, he is a pharmacist. So you see, it's all about people wanting to volunteer their time into educating people. So Adam, it looks like we are getting to our aim or achieving what we set off to do. Do you want to recap? We've done nearly an hour, so do you want to recap and quickly go through, and then if you want to finish off that with telling us more about like the personal stuff or your all your other activities, then we can. But just give us a summary of the eye, diabetes, eye health, and then we sort of finish off the program. And believe you me, we've done an hour already.
Oh, fantastic.
Yeah.
So in summary, so diabetes, it is a huge public health burden affecting different systems, healthcare systems around the world. It is a condition and a multi-system disease which affect different parts of the body as it progresses. And the good thing is, unlike back in the 19th century before the discovery of insulin, there are treatments, there is help that people can get. People can receive support. So the journey from diagnosis, treatment, and any other side of management, there is someone to support you, to hold your arm. I would also say prevention is better than cure. So since we've identified there's an association between lifestyle and the disease, there are opportunities to delay diabetes. There are opportunities to prevent diabetes. So the delay and the prevention aspect, this is where public health comes in. And then when that doesn't necessarily work and you've got a diagnosis, please ensure that you see your GP, get the support that you need, and attend retinal screening. The reason for retinal screening is so that we can detect the disease early and give you the support that you need. From retinal screening, there is every opportunity, going back again to those traffic light systems. So if we identify you at green stage, there's an opportunity to control good blood pressure, intensive blood pressure management, HbA1c. And then from there, if that doesn't work, again, it's not the end of the world. You get referred for specialist management. In the eye clinic department, there is lots of help and support again. And this time now, there is treatment, clinical management. But there's still room for public health. There's still room for disease control. There's still room to get it right. There's still room for lifestyle improvement. If, as you progress with your treatment, there are people, lots of people, there's lots of us around to support. I'm also seeing another role of the community coming together. And this is what has also been the positive impact of COVID in some situations, where communities have come together. we are now seeing certain areas such as the faith leaders coming together, inviting us to share this information. So it's again important that as a community we reach out to one another. So for those like-minded healthcare professionals, teach others, train others, empower them. And then the other thing also I would say that it's important again to show up for those appointments. And lastly, I would say that this is an African proverb. If you want to go fast, go alone. But if you want to go far, go together.
Okay.
So it's a journey. We are in this together. Let's continue to empower one another.
Absolutely. And that is such a good way to sum it all up. And I hope we've been able to capture all the very important things we want to come out of a show like this. Yeah, I'm all up for health education, and I know a lot of your team members are as well. So I've literally got the whole of the Moorfields Hospital team.
Lovely.
Yeah, wanting to come and share. And that for me, I think it's an awesome thing to do. You know, the desire to want to help our people through health, and especially through prevention, so we don't even get to that stage, is what we are trying to achieve now. So Adam, I will take this opportunity to say thank you. I don't know, was this what you expected?
Absolutely. Thank you very much. And I also want to thank all the viewers. I want to thank Doris, a good colleague of mine, for linking us together. I'd like to thank my my family. My wife was also watching there. My kids, our family. And my friends and colleagues from Moorfields. So part of the family, really, after having spent almost 18 good years there.
That's almost like a lifetime, isn't it? Yeah, I am so happy you came. And I'm very thankful for taking, I know you are so busy.
Thank you.
But we all share the same vision of wanting to promote the health of our people through health education. And I totally agree with you that prevention is always going to be better than looking for a cure for any condition. So viewers, I've had Mr. Adam Mapani in the studio. He is a consultant, a nurse consultant in Moorfields Eye Hospital, and he has given us great insight, more so trying to prevent us from getting to the stage where we will end up with all the injections or laser eye surgeries and all that. Yeah, so if we are able to follow some of these sessions, hopefully we will be able to stop us getting to the very bad stages. However, no matter what we do, sometimes we will end up needing some of these treatments, and trust me, you will be in capable hands when you come across people like Adam and his whole team. So we will be drawing a curtain on tonight's show. We are having a few technical hitches among the crew, the Omega crew, so I think we will probably not be back in 2 weeks' time, but I have a whole load of sessions coming up. Sessions in eye health, and where we'll be looking at glaucoma and all some of the other eye conditions that you can possibly come across. And then I have a gynae team as well, who is also going to look into a whole load of issues when it comes to gynecological health. So viewers, you will be doing yourself a great favor if you stay tuned in to Let's Talk About Health. It's been an awesome session. Thank you so much, Adam, for coming, and I look forward to you coming back another time. To the Omega crew, I say a very big thank you to Joe and the team, Mami Danswa, and all of the Omega to the world. And then, obviously, I'm looking forward to coming back in a few weeks to look into eye health. So look at my Facebook page, and then watch out for the next advert for the next session. On that note, I will say it's been great. So COVID is still around with new variants. Please stay safe. Thank you for watching and keep sharing. Thank you. Bye.
At World Remit, we understand what the journey is about. How it can sometimes take a little distance to bring us a little closer together. With ways to save more when you send more, World Remit is here for you, so you can be there for them.